Thanks, Jonathan, and thanks to the organisers for asking me to have a talk about this. I had to think a lot about this, and I suppose it's just more from an experience sort of perspective. And the way I'm going to approach it from the idea that ICU is a busy place. For all of us, you've got patients you're admitting, you've got discharge, you've got ward rounds, you've got procedures, you've got to go and see consults. And a lot of the things that we do, we think we help patients and our staff, but I think always in the back of my mind is that there's also a potential for harm. So as a director, I think I've got to need to be vigilant to both sides of this coin, and that whatever we do, there's a benefit and maybe a little harm. And I need, as a director, to put things in place to identify and monitor these. So what I'm going to talk about more are 5 concerns and more about processes than my top sort of ideas, if that makes sense. And hopefully you'll see this as we go along. So the first thing I think a director needs to do is to put in place systems to collect data. Without data, you're not going to really do very much. So the first thing is data with respect to activity. How are your patients sort of going through the unit? What are the outcomes of those patients? And ensure that you submit your data to the ANZIC's core data set. But then again, if you're going to put in other services, you're going to do a tracheostomy service, or you're going to run the emergency response service, or you're going to do TPN, monitor that as well. Don't just sort of think, oh, you know, we saw X number of patients for the year. But think about it and start it from the beginning, because trying to replicate it later on isn't going to work. The second thing that I think is very important is you've got to define what I call my standard operating procedures. And I suppose when I started many years ago, I needed to define the drug protocols. We will make up dopamine, which we used in those days, adrenaline, noradrenaline in this standard format, so that I could tell staff, set up a noradrenaline infusion, and they would do it exactly the right way. I think this is just second nature. We all do it now. But also, how do you ventilate patients? When do you start feeding your patients? So I like to say, look, the patient comes in, they're going to be ventilated overnight, you need a nasogastric and you start feeding tonight. That's become a standard procedure within our hospital. If you have a cardiac arrest, which hypothermia protocol are you going to follow? What's your glucose management going to be? What's your standard setting for when you want someone on a hemofilter? So you can say, start hemofiltration, and you don't have to go through 10 other lines of information as to what you want, unless you're going to do it a little differently. And we put all these down into what we call suggested practices. You can't call them protocols because that has other implications, but just suggested practices. And this is in a PDF format that I can put on a phone, a tablet, or I can have on the intranet. And please don't take notice, this is an old one, so it doesn't have my latest sort of versions of some things on it. The next thing I think one needs to do is to look around and start putting in evidence-based practices. Now, that includes every ward round, is there good evidence around every element of the fast hug? But it's simple and everybody does it, and we expect people to do it. Years ago we had a ventilator bundle. Didn't have anything to do about ventilation, but DVT prophylaxis, head of the bed elevated and so forth, and we implemented those. And maybe we should be looking at a little more. If any of you know the Society for Critical Care Medicine, they've actually now brought out a whole range of things called the A, B, C, D, E and F elements, which include things around families as well, and quite a bit more patient focus. So have a look at that and think, is that important to do? I have a little bee in the bonnet about low tidal volume ventilation, as you may have heard or might hear this afternoon. Again, temperature control, early nutrition, and you've heard the CLABSI sort of collaborations, particularly what's been happening in New South Wales. These are all very important, and we need to establish them, and I think it's up to the director and the team in order to put these in place. You do need to look at your mortality, not just the mortality of people who die in ICU, that may be 10%, but the other 5% of people who die on the wards. You know, we need to do this regularly. What's the morbidity? What about our readmissions? What are the patterns of readmissions coming in? As we might be able to prevent some of those, or you know, it may be the patient that's the reason that's coming in rather than something we didn't do. My priority number 4 is if we do these things, we need to monitor them. And it doesn't mean that the director has to be the one that has to get in and do all the paperwork and put things into databases, but you can involve other people in these projects. Our nursing colleagues are very good at it. Our medical students, there are registrars. Everybody has to do a project at some point in time. So why not enlist those people as part of the project to initiate it for you and to get it into place? Debriefing post-procedures and events. I've quite enjoyed doing this, that if we do a tracheostomy or we do a central line or we have a cardiac arrest, I like at the end of it to go and ask people, well, what do you think we did really well during that procedure? And then ask them, well, what could we have done better? You know, I didn't open this pack on to the tray before I started, or I forgot to load the dilator onto the tracheostomy tube and things. But I think it's important because it gets people thinking that they can talk about these things, and it's a nicer environment, and it will improve how things are done down the future. And the last one that I've got there on that list is staff well-being. And there's a session today, is it going now or early this afternoon, that's looking at burnout. And there's been a lot happening in the literature in recent times about what the impact burnout has on staff. And at the recent American Thoracic Society, they said if people are beginning to get a bit jaded with their job and maybe heading towards this burnout syndrome, they don't work as well and they become dangerous in the environment in which they're working. And I think that's a big safety issue. If you don't see the warning signs of this happening, then people aren't going to function as you expect, and you may find harm happening. People may forget things or they may not do things properly. So I think staff well-being is important, and some of you may have seen David Reid, who's our data manager, but he's also a counsellor, has got an interesting little project around monitoring people's stress levels on shifts and making sure they're not given too many stressful shifts in a consecutive period of time. My priority 5 would be to set up good reporting structures. Discuss the things that we've been talking about, the mortality, the readmissions, our CLABSI rates, and all those things need to be part of the business meeting. And we have a business meeting every week, and the first 15 to 20 minutes just looks at that patient data. Who died? Who got readmitted? What happened to patients on the ward? What happened with all the Met calls? What were the trends that we saw? We have one person looking at every Met call, and that person then reports back weekly as to the trends that they're actually seeing. Run education meetings within the ICU to provide that feedback that's very important. Produce reports to hospital executives. If you collect the data, you're the only one who really knows what's happening, and in your report saying, I need more staff, or this is what's happening with our patients, our delayed discharge rates, so on and forth, they don't know. You're the only one who has the data, and I think having data is very powerful. We need to report to the quality bodies like ACHS, and for some, there's another group called the Health Roundtable that our hospital contributes to as well. And importantly, look at those reports you get back from ANZIC's core about how you're going compared to other people. So in closing, just some general sort of comments I'd make. Don't try and implement everything on day one. It's taken me 30-odd years to get a lot of these things in place, so time is on your side. But set the priorities and just sort of keep doing things. From a director, but for you clinicians, you can set these up and you can raise these as they become more important. As I said, use people who need projects to do it, and use administrative data that is available in the hospital. You'd be surprised what's collected in those PMIs or PASs in there. There's a huge amount of data that you can tap into that has relevance to your intensive care unit as well. So thank you very much.